vulnerable. Yeah. Next slide, please. So here we're talking about the same. So remember, we started with the prevention. We've gone to how best do we engage these populations. This slide talks about early engagement of these populations, especially those that are on antiretroviral therapy. How do we best engage them so that they access, services like viral load? Again, it's an issue of how do we best synchronize interventions around the health facility and those at community level. Next slide, please. So this slide talks about service delivery models. Okay, different service delivery models. There are quite a number. Okay, there are peer-to-peer, models. There are community-based organizations that are working. I'm sure in your various provinces, in your various communities, there are networks. For example, for people living with HIV, there's a network of Zambian people living with HIV. Okay, for adolescents, there are quite a number of initiatives that have been put together. We're talking here about the dreams, for example. We have the Zambia Youth Platforms. We have many other initiatives that exist, and these are some of the initiatives that are currently being used to reach out, to these populations, and also as a mechanism to reach out to these populations. Next slide, please. I think next, I've spoken about this. So let me just go to the summary and just indicate quickly that as I indicated, priority and vulnerable populations are those that are at high risk of HIV, and is higher in these populations. And if this is not addressed as a result of many factors that include stigma and discrimination, you note that we may not attain as a country and even as a region our vision to end AIDS as a public health threat by 2030. And when you talk about 2030, we are talking about the next 8 years. Okay, so one of the issues here, coming out is that at facility level and whatever level of service delivery, I think we need to address the issues around provision of free services free from stigma and discrimination, and also the need to invest. I know that currently we have DSD guidelines. We need to utilize these guidelines to reach out to different, populations that require these services. So and there are references there. So the basis of this presentation is the COP 2021, the National AIDS Strategic Framework 2017 to 2021, the revised National AIDS Strategic Framework 2021-2023, the Global AIDS Monitoring Report 2022, the UNAIDS Report 2019, the Prison Assessment Report 2021, and the Zambia Demographic Health Survey 2018. Thank you so much, Chair. I know below there are some poor questions that we need to respond to. I think yes, this is the question for you, Chair.
Yes, thank you very much, Dr. Mwale. You've really done a great job on this, and I appreciate your summary, and especially emphasizing the DSD models that we know that these are person-centered care, looking specifically at the issues that are affecting the person themselves. And so we want to appreciate the work that you put in putting this together. Allow me to also introduce to you, our colleagues. We have on call our panel of experts, Madam Linah Mwango, who's joining us. Also, we have Dr. Jackson Okuku, and then we have also Dr. Bosco. Very familiar names. I think we've interacted with on this platform before. Thank you very much, colleagues, for joining us. And I could see that Dr. Okuku had already gone into full gear responding to some of the questions that were being posted in the group. So what we'll do first, before we take any questions, is I will launch the first poll question. Let's see, today we'll do it differently. We want to see how people are going to respond to the poll questions after the discussion. And then Dr. Mwale will come in to just emphasize. And then after that, then we'll take on the questions from everyone. So people already started responding. The following are priority and vulnerable populations: MSM, sex workers, PWID, prison inmates, and transgender. Is this a true statement or false? So we've done about 40 seconds. So we'll give you a bit more time to poll. Okay. All right, so allow me to end the poll now. Only about half of the people have managed to poll. Dr. Mwale, you can have a look at the results and you can make your comment.
How do I check?
No, just go to the screen if you can see.
Oh, okay, great.
Yeah. So most people think it's a true statement. Most people think this is a correct statement. Any comments? Dr. Mwale?
I was being distracted by the results.
Yeah, so I was saying that most people think it's a true statement that the following are priority and vulnerable population.
So most people think these are priorities. So, so the thing is that, and I think the panel agree with me that it's true or false. because you see, priority populations, we're looking at, like I indicated, we're looking at adolescent girls and young women. We're looking at people living with HIV. We're looking at women. We're looking at the old, those that are above 50 and all that. Okay. But the description of the list that is being, said to be vulnerable, priority and vulnerable population, these are key populations.
Okay.
Yeah.
All right. No, thanks a lot for that clarification. We'll share the next, we'll launch the next poll question. So this one is asking the following key population service delivery areas. Sorry. The key priority service delivery areas except, what is it keeping? So if you were following on the slides, you will be able to see which ones are which here. And so far, we have got people polling. Okay, so I'll share the results. this is how the people have responded. Most people think condom use is incorrect, but the rest are actually service delivery areas. Any comment on that?
So the comment here is that even condom use is it's a KP service area.
Okay.
A KP service area, but also, you know, there's an introduction which has not been so much part of the ZAM's you know, supply chain mechanism, but it has started now. The lubricants. Okay,
Yeah.
so we have condoms, we have lubricants, and all those. So the right answer is, I mean, all of them except nothing. All of them are KP service delivery areas. Yeah.
All right. No, thank you very much for those for that response. So, dear network, there you have it. If we have got any other questions that you would like to ask, we have a panel of experts here on the call. And perhaps for those that were not able to look at the chat, we had a question initially that was asking about what does mathematical model mean? And it was ably answered by Dr. Okuku that this is just an epidemiological information that is sort of generated from modeling, mathematical modeling of certain equations. Yeah, and in addition to that, this is typically used when it is either impossible or impractical to create experimental conditions in which scientists can directly measure the outcomes. So those are some of the additional comments on that question. And then there was another question whether I think this question came in asking how can that they're curious to know how a trans woman can get pregnant. And this was answered also by Madam Linah, saying that it was a trans woman and not trans woman, it was a trans man, and there was an apology for that. We have seen people being tested twice, thrice, because they did not disclose their status. What strategies are you putting in place to avoid duplication of numbers? And so I think we'll get a response to that as well. And so if there are any other comments from the panel of experts that you would like to make, please go ahead. You can raise your hand and make any additional comments and points of emphasis in this discussion. Please feel free to do so. And from the network, if you've got further questions, please go ahead and do so. Thank you so much. Yes, Joseph, Yowela, please go ahead, unmute yourself and ask a question.
I didn't want to ask a question, but just maybe to make a contribution to the presentation. Unless you want to get
contributions are very much welcome. Please go ahead.
All right, thanks. Thanks, Dr. Mwale, for that comprehensive presentation. And I think it's very critical for healthcare providers and everyone that is involved in a society to be able to understand this key population of vulnerable groups, because these groups actually do exist. So these are the ones who are at risk of contracting disease, or maybe sometimes, you know, they may be left out in the treatment and the prevention program because of various reasons. And I think some of the reasons could have been given. Some of the reasons could be because of, you know, their legal status. Sometimes maybe because, you know, they're associated with a group that is seen to be an outcast. And I think there's been examples of the groups that have been given. These do exist, and the challenge is there to be able to provide the services. And it's very imperative for every one of us to be able to come up with ways to be able to provide services to these ones. I know there are so many strategies that could be used. I mean, most of us here are experts. And we should be able to think about how, the practical interventions to be able to reach out to these population groups, because these population groups, some of them are actually hidden. Some of them are groups that we know, but how do we actually go to those people and reach out to them? One of the things I think Dr. Mwale was talking about, the issue of stigma, if we can reduce the stigma, and that is working with various institutions. Sometimes working with religious leaders is also very critical to create awareness and making sure that they also understand the importance of these priority groups and how we can be able to provide, services. I can give an example. I know most people in Zambia being a Christian nation, you talk of the Christians. There's an example I can pick, which is very close to me, which could be, used. I think that when Jesus found a lady who was caught in adultery, he did not condemn that woman. He embraced her, he showed her the way, and he guided her on what she should be doing. In the end, that woman was won. But I think the problem that we've seen nowadays is the challenge of stigma. And because of that, we tend to push people away from the health service. Now, it's very critical for us to see how best we can be able to capture these population groups. Sex workers, for example, sometimes people bury heads in the sand, thinking that these do not exist. They are there. When you have a conversation with them, you find that these are people who are just normal because of various circumstances. They find themselves in those areas, and we need to reach out. Sometimes you can work with groups which are called change agents. Some of them, we've seen some works where you get former sex workers who have transformed to be able to reach out to the sex workers and provide the services. An ordinary person who does not understand how they operate, it becomes difficult to reach out to these populations. So we need to identify those groups and reach out to them to provide those services so that we can be able to, end this problem. Sometimes, service provision is only towards those people that we can see, but I think these hidden groups need to be reached because they interact. Another example would be the migrants and mobile populations. And I think the definitions of these population groups sometimes tend to, affect how the services can be provided. A lack of understanding now makes us to struggle to provide their services. Mobile populations would be those populations that are actually moving most of the times, like truck drivers, but regularly go back to their homes. Then migrants are those who could have moved for a long time or for a specific time, and then maybe later on come back. With all these movements, mobility, you find that there are various risks of contracting, disease. And these are groups that we must be able to capture and find ways to be able to provide the services for them, because they've got unique needs. They've got unique circumstances that actually make them to be at risk. So as experts, it's always good to look at how best we can be able to capture. Could be the use of the change agents, understanding who these populations are, and ensuring that we provide, the services. For health workers, I think it's a caution to us. Stigma, we have to get rid of it. Let's understand these populations and provide, the services regardless of certain barriers that can be coming our way. I thought I'd just add this. Thank you so much.
This is very, very well elaborated addition points. Thank you very much. I appreciate your defining a bit of mobile population, migrant community, and all those things. Thank you very much. We already even have a comment here from Lundazi Lumezi. They are saying that they've learned quite a lot from this and meeting, and that they'll be able to share the knowledge with their colleagues. Don't worry, we will share these slides with you. You will receive them and feel free to actually present within your facility to orient your colleagues there. Any comments from Madam Linah, Dr. Jackson, you would want to make emphasis on? Dr. Bosco, any comments, additional comments?
Hi, Dr. Ziambo.
Hello.
Yeah, just so interesting, and also to see how engaged the network members are, and also happy to see that we're able to clarify between a transgender man and a transgender woman. I'm sure people have really learned a lot and seen the difference between the two trans populations. Otherwise, thanks to Dr. Mwale for elaborating most of the key issues.
Thank you very much.
Thanks, Chair. This is Dr. Okuku. I really want to appreciate the contributions from Dr. Mwale and the other members of the team around him, Linah, Bosco. I just want to add that this population group, as Dr. Mwale John has mentioned, do exist, and they come to our clinics. I personally remember when I was working in one of the general hospitals, and I was not familiar with this population at that time. I had someone come into the office who had florid anal warts, a male who came into the office, and in the perineal region, there was florid infection with anal warts. And at that time, it was shocking. And as a clinician who swore the Hippocratic oath after graduating from medical school to do no harm, how was I supposed to respond? Was I supposed to jump in fear and in shock and scream at the roof and begin, or what was my obligation as a clinical health service provider? So in that situation, of course, inside me, I was a little uncomfortable because it was a new area. And I had seen warts before, but not to that degree, and not commonly in that particular region. But I hid my fear. Then I was working with Reverend Dr. Johnson. Those of you who know him, Stephen Johnson, who was a surgeon, one of the Catholic priests. And we attended to this man and supported him and so on. So the point I'm making is we have cases like this coming to our clinics. And I think our primary responsibility as care providers is to respond ethically, professionally to their service delivery needs. And because as far as the HIV epidemic in Zambia is concerned, if you look at what John presented, they are a significant group that we must support to ensure that we reach epidemic control. The biobehavioral study that was done some years ago, I think that was done by FHI 360, that revealed that HIV prevalence among female sex workers, for example, is 56.4% on average, was from Zambia, which meant that 1 out of every 2 female sex workers at that time was living with HIV. The question I want to ask you is, who is patronizing the sex workers? It is your brother, my brother, people in our churches, people, our neighbors, our relatives, our friends, and so on and so forth, people all around you. So if we do not respond and ensure that no population group is left behind, at the end of the day, achieving epidemic control as a country will be a dream and not a reality. And imagine how much we are spending on medications. For example, not too long ago, the US government supported the Ministry of Health with the Zambian government with, that's through PEPFAR, over $400 million to support this issue and support our effort at HIV prevention. This is money that can be better channeled to more constructive developmental issues if we just curb the epidemic as far as HIV transmission is concerned. So it is necessary that as clinicians, we respond to these population groups professionally and ethically because they exist amongst us. And we have a duty based on the Hippocratic oath that some of us swore to respond this way. Over, thank you.
Thank you very much for bringing up that work ethic. I think it's an important issue that we ought to carry around us if we want to close the last mile. And you will realize that these vulnerable populations actually, and the key populations actually are the ones that also contribute to the driving the epidemic. And if we really look at some of the incident infections, it's among young groups of young people around in these areas. So thank you very much for emphasizing that ethical conduct in our workplace. Are there any other comments from the network? Today we don't have a case, so we just wanted to have this discussion and just appreciate an important aspect of healthcare delivery to the priority and vulnerable populations and the services that we can possibly deliver and how we can avoid discrimination and stigma for this community. Any other comments, questions from the network? If there are no other questions, then we will have to end here for today. Okay, there's a comment in the chat. And this is from Chisha Samson. If we can create a conducive environment for everyone to access services, we are going to win the fight against the epidemic. I have attended to a number of clients who have asked me what they would do if they moved out of town, bearing in mind the stigma concerning them. Chisha Samson, would you like to unmute yourself and make a comment? It's from PPAZ in Livingston. Would you like to unmute and just really amplify on what you've made a comment on in the chat?
Thank you so very much, Doc. So on that one, of course, I have attended to a number of KPs or the key populations, and it becomes a challenge for them to access services when they move out of town because of their sexuality, okay, or their nature of activities that they involve themselves in. Mm-hmm. So if other facilities can be able to accommodate them in terms of providing the services to them without stigma or discrimination, then we can be able to do well in that area. Because yes, these people are there. They are our brothers and our sisters. We need to love them just as we love those that we think they are straight. But we have to involve, all of us have to put our hands together and help them.
Thank you very much for that valuable comment. Michael Chanda, I've seen you've raised your hand. Please go ahead and unmute yourself and make your comment.
Oh, thank you very much, Doc, and thank you, colleagues. Let me make a small contribution to this very exciting yet important topic. Doc, in my analysis of this topic, I note that most often as health workers, we discuss it from a health point of view or a medicalized point of view. And okay. I have come to realize that when we are talking about KPs, it's actually a way of life. And because it's a way of life, we need to go a step further to appreciate what factors are surrounding, what ecosystem subsists or what ecosystem surrounds these KPs. And in order for us to do this, Doc, I am encouraging that we involve the social behavioral scientists a lot more than we have done, because then and only then are we going to appreciate the social network theory that surrounds the sexual network theory. For us as health workers, predominantly, we are talking about the sexual network theory, but the sexual network theory is predominantly a denominator of the social network theory. And that's why I would say in our interactions with KPs, let's see how we involve the people that understand the social fabric of society and the psychosocial, not the psychosocial as we know it. I'm talking about the actual going into the psyche and also understanding the social fabric and the determinants of the KP as a denominator which we deal with. Otherwise, it's a fantastic discussion, and big ups to all those who are doing direct work in this very almost complicated aspect of our society. Thank you, Chair.
Thank you very much. Indeed, yes, indeed. And I completely agree with you. Involvement of multi-stakeholders like behavioral scientists and all those things are very important conversations to have, because some of these behavioral and adaptive kind of problems that may not really respond to very technical and scientific discussions like you're mentioning. Dr. Mwale, you want to make a comment? I've seen you have unmuted.
Yes, no, just a quick one that I know, Chair, you're about to end the meeting, but just to say, Chair, this is a very important conversation, and I appreciate how wide the network is, and I think this is an appropriate network where quite a number of issues can be discussed. This is a real issue, and when we talk about stigma and discrimination against these populations, they are real. And yeah. we shouldn't focus only on KPs, but even just overall adolescent, just overall priority population, adolescents, people living with HIV and all that. So it's a matter that we need to deal with, all of us as health care workers. But also to mention that as we deliver these services, we have organizations, for example, in the presentation on service delivery models, there are quite a number of organizations that are working with these priority populations. For example, for the trans, we have an organization across the country, the Trans Bantu organization. It's there to provide technical services. This organization also engages religious leaders. They engage political leaders. They engage traditional leaders and all that. Even us at health facility level, we can use these organizations. We have quite a number of them. So I think, Chair, for me, it's just to thank you and the team for giving us this opportunity as a team to share some of this information, particularly the ECHO coordinator, who worked tirelessly, Tambuyu, Dr. Sombo, yourself. Thank you, Doc. You were communicating around 23 yesterday. So thank you so much for this opportunity. And also thank you so much for the team that has joined the meeting. I think let's continue, sharing this information where there are issues. Let's share ideas and move ahead as a team. Over, and thank you so much, Chair.
I think you've done a very good job of just summarizing our discussion this afternoon. And I think these discussions and conversations need to be picked up as we continue. And I think as we provide technical support services, supervision, and technical assistance, I think let's look at how we can provide this support within our facilities and just help to make this awareness of being able to remain ethical, provide these services to these priority population, vulnerable populations, as we try and achieve epidemic control. So I think we've come to an end of our session for today. Thank you very much, everyone, for being participative, and you've been very interactive in the chat. And we'll see you next week as we'll be looking at non-communicable diseases in HIV. How do we care for these? And we know that non-communicable disease is another pandemic that we actually seeing that is affecting, cross-cutting, affecting everyone, whether HIV or not. And so how do we see this in the HIV programming? So please, let's meet again next week. Thank you, Dr. Okuku. Thank you, Madam Linah, for this opportunity. And thank you to the rest of the network for joining us from different places across the country. And we appreciate for your continued participation. We'll see you next week and have a very good week ahead of you.
Thank you. Bye.
Thank you, Chair.